So I'm going to talk about first-line HIV treatment to avoid long-term toxicity and drug-drug interactions. I won't be very long on toxicity, following a beautiful talk by Jose. These are the guidelines that EACS put together not too long ago. And you can see that there's a lot of novelty if you compare them to those that were available years ago. And you can see how important integrase inhibitors have become together with tenofovir TC, and in terms of dolutegravir also with abacavir and 3TC. There are still protease inhibitors. There's darunavir, ritonavir plus tenofovir and FTC as recommending first-line treatment. And in terms of NNRTI, in terms of first recommending combination, we remained only with rilpivirine, tenofovir, and FTC if someone is naive with a viral load lower than 100K. And you can see that there's a lot of alternative. And efavirenz, our efavirenz, the one that we have the most experience with, has actually now become an alternative. And we know very well why. It is because of the central nervous system side effect. It is because it seems to be associated to worsening of neurocognitive impairment long time. And it also has been associated to high rates of suicidality compared to other third agents. So I don't think there's any further need to talk about efavirenz. But there's a lot about central nervous system side effects and antiretrovirals. And when we look at drug SPC, we read things like this, which we are used to experience with efavirenz. So the drug can cause depression, suicidal ideation, behavior, particularly if there is a pre-existing history of psychiatric illnesses, depression, and the drug should be used by caution. What drug is that? Do you think it's efavirenz? What drug am I talking about? It is raltegravir. It is the perfect drug that was, do you remember? It wasn't associated to any toxicity, any side effects. It was perfect. It had absolutely nothing. But then actually, if we go and look in detail, sometimes at the results of phase 3 clinical trials, but especially of cohort studies, integrase inhibitors that are indeed the new fantastic class drugs that have changed and remarkably improved the treatment of HIV can be associated to suicide ideation, to depression, and this is true for all of them. The only one that has at the moment only been associated to depression, and depression is uncommon, is Genvoya, that hasn't seen any suicide ideation during phase 3 clinical trials. And we don't have a lot of experience of using Genvoya in Europe, and I really look forward to that, to understand better. And also, it is true for NNRTI like rilpivirine, which are definitely much better tolerated than efavirenz, but they also have shown to be associated to psychiatry side effects, and insomnia, depression, sleep disorder, anxiety, and so on. So again, just to kind of sum up and link to what Jose said, we talked about the bone, the fact that people living with HIV are at an increased risk of low bone mineral density and fractures, and some drugs like tenofovir and boosted protease inhibitors have been associated to this increased risk. From the D.A.D cohort study, antiretrovirals have been associated to the development of chronic kidney disease, also in patients with an initial normal renal function. And this was true for long exposure to atazanavir, ritonavir, lopinavir, ritonavir, and tenofovir as administered as tenofovir disoproxil fumarate. And then there is a link between certain antiretrovirals, and Jose said, and the risk of myocardial infarctions, and it is abacavir has been shown from the D.A.D study to be associated to a higher risk of MI, and in terms of third agents, it was lopinavir, ritonavir, boosted PIs, and these are the data up to 2008, and I know there are updates on that. So then a new booster, COBI sister, has been introduced into clinical practice. And I think we were all a little bit hopeful that it would replace ritonavir also from a safety point of view. But the head-to-head clinical trial, the 114, that compared atazanavir, ritonavir to atazanavir, COBI sister, actually didn't show any significant differences in the safety associated to the use of the drug. So, and that was also true for the phase 3B single-arm study of darunavir, ritonavir, darunavir cobicistat, sorry, they compared the findings with the phase 3 naive studies. So we published an editorial because we wanted to celebrate the use of boosted protease inhibitors for 20 years. Following, so this is 20 years following Vancouver at the IAS in 1996. So if you're interested in what boosting actually is today, that's what I wrote with David Beck and Jose Gatell. And boosted protease inhibitors indeed have benefits because we know that using a booster for certain drugs is very important to enhance the exposure and prevent toxicity. They have a high genetic barrier. We can use them with less frequent doses. They may be optimal agents in people with poor adherence, but they also are associated to risk. And this is why we're probably moving away from using boosting agents unless they're very necessary, because people who use them, who are prescribed them, might have developed resistance in the past because they're associated to risk, like drug-drug interactions, tolerability, and again, sometimes kidney disease or cardiovascular risk increase. So if we think about drug-drug interactions for a moment, we can look at this table that just kind of classifies the different antiretrovirals and sees which ones are associated to a higher potential for drug-drug interactions, to an intermediate potential, and to a lower potential. And you can see that using a booster, so ritonavir and cobicistat, again, to boost either atazanavir or darunavir or elvitegravir, puts the drug into the category of higher potential for drug-drug interactions. And this is similar to what happens to NNRTIs like efavirenz, nevarapine, etravirenz, because they are inducer of cytochrome P453A4, another metabolic pathway. So they are characterized by drug-drug interactions, and we need to know this when we see people on antiretrovirals that are on many other drugs. In terms of moderate potential, we have rilpivirine and maraviroc there. And rilpivirine and maraviroc have no effect on other agents whatsoever, but they are substrate of cytochrome P453A4, so they can be affected. Their exposure can be changed either by inhibitors, like ritonavir and cobicistat, or by inducers, like many others, like carbamazepine, rifampicin, and so on. And then there are drugs associated to a lower potential for interactions like raltegravir, most NRTIs, and dolutegravir with few exceptions. So it's a little bit moved towards the moderate place. So this boosting story is just that ritonavir and cobicistat inhibit cytochrome P453A4, so it is a fantastic, favorable, positive drug-drug interactions when you think about the levels of elvitegravir or again atazanavir or darunavir, because by inhibiting cytochrome P453A4, they allow the drug to be administered at a lower dose with less side effects and so on. But obviously the downside is that other substrate of 3A4 that are administered will also be affected in terms of drug exposure, and sometimes toxicity can be developed by the patient. If you're passionate about the differences between cobicistat and ritonavir, this is a very useful review that was recently published by David Beck and his groups, because there are some differences between the two boosters that might be useful to know in clinical practice. The most important characteristic is the inhibition of 3A4, and that is where they are actually very similar. But there's also some differences because ritonavir also induces other metabolic pathway, like certain cytochrome P450 isoform like 1A2 or glucuronidation, the phase 2 enzyme process, while cobicistat is much more an inhibitor and mainly of cytochrome P453A4. So if we look at the guidelines again, we talked about how difficult it could be to use boosted agents, but 10 of the 17 regimens in the whole guidelines still have boosters. So although, as I said, we are moving away, although raltegravir and dolutegravir, which is unboosted agents, and rilpivirine are advised as first-line regimens, we still are using booster in clinical practice a lot. But boosting and inhibition of cytochrome P453A4 are not the only mechanism behind drug-drug interactions that we need to know about. There's many more, and this is to ensure the well-being of the people that live with HIV and take antiretrovirals. So we need to know that drug-drug interactions may occur at the level of absorption, either with food, with minerals, with supplements. They can occur because there is a change in gastric pH with antacids are given, so antacids or proton pump inhibitors or H2 blockers, or they can occur because first-pass metabolism, and so absorption at the level of the gastrointestinal tract is affected because of transmembrane transporters or cytochrome P453A4 at that level. Drug-drug interactions that we talked about can be affected because metabolism is altered by drugs, so it is inhibition or induction again of cytochrome isoforms or transmembrane transporters or glucuronidation. And they can also occur at the level of excretion at the kidney. And Jose did mention about knowing about OCT2 and MATE1 and influx and efflux transporters at the level of different organs. So in terms of interactions at the level of absorptions, people living with HIV or antiretrovirals can be at risk of these interactions, either because, again, they need or they take drugs that affect the gastric pH. So giving atazanavir and rilpivirine with omeprazole, for example, is contraindicated because these are drugs that are characterized by a pH-dependent absorption. Very importantly, integrase inhibitor must not be given at the same time with polyvalent cations that are present in some products. So high doses of magnesium, aluminum, calcium can be in supplements or antacids. So pharmacists usually should advise our patients about what to do and how to take the drugs. And then again, drugs that induce and inhibit cytochrome P453A4 of efflux transporters. This is just a graph to show you what happens if you take elvitegravir together with antacids that again contain high levels of magnesium and aluminum. So you have just to make sure that you take them at least 4 to 6 hours apart. Ideally, when you are in clinical practice, if someone is on a once-a-day regimen, it's quite easy to just say take them 12 hours apart, and then you are quite sure that there is no interaction at the level of absorption. But all the integrase inhibitors and MPCs are very, very clear on what to do. It's just that when you measure the concentrations of elvitegravir together with the antacids, taken again simultaneously, they're much lower than they should be, or they're much lower than elvitegravir alone. So I'm going back to that story of the transmembrane transporters. I sound a little bit obsessive about it. My friends, Laura including, always tease me because they say all I talk about is PGP. I guarantee you I talk about other things, not much, but it is really important because it is a very important drug-drug interaction mechanism behind a lot of interactions we see in clinical practice. So we are very much used to think that it's all about cytochrome P453A4 and ritonavir, but there are other mechanisms that we need to know. So Jose has become a renal MATE1 expert, he was saying. These mechanisms are behind a lot of drug-drug interactions that we see between antiretrovirals and DAAs, so the direct antiviral for the treatment of hepatitis C. And I hear sometimes that there are no interactions between antihepatitis C and antiretrovirals. It's not a problem at all. And I'm not saying it's a problem. The drug interactions are usually manageable, but sometimes I think it's also the lack of knowledge of what the mechanism behind the interactions are. So basically, this is the liver cell, and this is the blood. And drugs like rosuvastatin, for example, need to enter the liver cell, and they use some doors, some influx transporters, and then inside the liver cells are metabolized, and they need to be eliminated in the bile and use some efflux transporters to get out. Importantly, inside the liver cell, they exert also their pharmacological activity, so they must get into the liver cells to work too. But if I give rosuvastatin with ritonavir, ritonavir inhibits OATP1B1, so inhibits the entrance of rosuvastatin into the liver cell. And this is why when I give them together, I observe an increase in rosuvastatin concentrations, which is remarkable because rosuvastatin cannot get into the liver cell as well as it would do without ritonavir there. And also there is an inhibition of the efflux transporter, so there will be more drug inside the liver, but it takes a long time for the drug to enter. And this is also why sometimes statins don't work as well in people with HIV. It's a multifactorial factor, it's very complicated, but let's not forget about the drug-drug interactions where the statin is around, there are good concentrations systemically, but it cannot get into the target, basically, cannot reach its target. So I'm just going to through a story of this man. He's 61 years old and has a symptomatic MSM, which is diagnosed with HIV. His CD4 cell count is 230, his plasma viral load is 80,000. And this is quite common, something we see a lot in our clinics. They were talking about rates of HIV transmission going up, so we're all used to see. But this man comes and he's already on some medications. So he's already on polypharmacy, because being on polypharmacy just means of being on 5 drugs or more, because it is when you are on 5 drugs that you are a higher risk of toxicity because of drugs and drug-drug interactions. And it's because he's already affected by some comorbidities, or this is how we call them in our field. He has hypertension, benign prostatic hyperplasia, hypercholesterolemia, asthma, and depression, but he's not on treatment for depression. He's on amlodipine, on tamsulosin, on simvastatin, on fluticasone. And he's taking multivitamins, and he also says he's taking methadone as recreational drugs every other weekend. So he's doing fine. His baseline tests are okay, doesn't have hepatitis B or C, he's HLA B5701 positive, but nothing really relevant there. His GFR is okay. So when he comes to see you, he wants 1 pill once a day with no side effects, please, and that's your job. And if you can do it quickly, it's even better. So you have some treatment options to consider. Different countries, different towns have different cost pressures. So obviously we're not going to cover that, but he has options, NRTIs with raltegravir, NITIs with NNRTIs, raltegravir, or other integrase inhibitors, and so on. If his baseline resistant test is wild type, he probably doesn't need the protease inhibitors to start. So the question here, is it essential for the patient to have a single tablet regimen? And it's something that we probably have to assess and see what his adherence would be if he doesn't. But in terms of polypharmacy and drug-drug interactions, so when prescribing or switching one or more drugs in an antiretroviral regimen or an antiretroviral regimen to someone on so many drugs already, we need to consider the potential for drug-drug interactions and manage the doses and go through what the patient is on and sometimes change whatever co-medication he's on and he needs to be for a long time in the future. So I'm just covering an example. So we said he was on amlodipine 10 milligrams once a day, and his hypertension is controlled. So if you start a boosted protease inhibitors or elvitegravir cobicistat that inhibit cytochrome P453A4, you need to think about it, because amlodipine exposure will go up because amlodipine is a cytochrome P453A4 substrate. So you need to make sure that you either give less amlodipine, and you try to give 5 milligrams and see whether the blood pressure is still controlled, or you completely change antihypertensive. You work with the general practitioner to make sure that you avoid the toxicity due to overexposure of amlodipine. On the other hand, if you start efavirenz or nevirapine, which are still widely used in Europe because of cost pressure, because of experience, even if there are alternatives, on the EACS guidelines, you need to make sure that you still control the blood pressure of the patient, because they will push down the amlodipine exposure, and therefore the person you have in front of you might have hypertension again, even if it has been controlled for a long time. So you either again change antihypertensive, alter the dose, monitor. So there's quite a lot of work to do that you can either do yourself or refer to the general practitioner that probably will then refer back, because he wouldn't know how to manage drug-drug interactions with antiretrovirals. This gentleman was also on fluticasone for his asthma, and as you know, it is very important to assess every patient that comes that is on ritonavir or cobicistat and make sure that they're not receiving steroids, with the exception of beclomethasone, because of the important interactions that can occur. And the literature is full of case reports and reviews about consequences, about iatrogenic cushingoid in people living with HIV on ritonavir, and now also cobicistat. They're coming out. So this is really, really important. I saw one last week again, a young man on rilpivirine, darunavir, ritonavir, coming in with cushingoid evident and being very sick. It just never stops. And then recreational drugs. I'm not going to talk a lot about this, but there is a very high use of recreational drugs in MSM, with and without HIV, that we are observing in the capitals of the world. I left this slide in my talk because actually this is the level of drug use among Asian MSM, which is very similar to Europe. So when I started to understand this problem that MSM use drugs like crystal meth, ecstasy, GHB, mephedrone in the context of chemsex, I thought it was also only in London, and then you just discover that it's massive and it's everywhere. So I was speaking in Taiwan, and they were all talking about chemsex in Taiwan, in Taipei, in Hong Kong. So it's really, really a problem everywhere. What we don't know, unfortunately, is whether we need to worry about drug-drug interactions between these agents and antiretrovirals. And again, mainly I would say boosted agents, so antiretroviral regimens containing ritonavir or cobicistat. We published this review in AIDS last year that hopefully gives a little bit of guidance on what to do, but we don't know whether the inhibition of certain metabolic pathway can make these drugs more toxic and lethal. The Liverpool website also has a chart to guide care providers on how to advise the patients depending on what antiretroviral combinations they're on, and also on what recreational drugs use. And so this patient, for example, just said that he uses mainly mephedrone, which is a synthetic stimulant drug of the amphetamine and cathetone classes. It's also called Ronem, Cat, and Meow Meow, which I advise you to learn the names of the drugs, because sometimes that's the names that are used. A few years ago, I was in clinic, and the first time I saw someone walked in and said, "I'm high on Tina." And I had absolutely no idea what he was talking about, because I didn't know that crystal meth was called Tina. So the mephedrone is used as tablets or powder and can be swallowed, snorted, and injecting, and it does produce similar effects to MDMA and amphetamines, and it is metabolized by 3 phase 1 pathways, and it's involving cytochrome P452D6, which is only moderately inhibited in terms of activity by cobicistat, and it's very different than 3A4, so we don't really know whether people on boosted PIs or on boosted PIs would have more toxicity if they use mephedrone. What we are learning, there was a chemsex forum in London, and it was really interesting because people from different countries in Europe were presenting their data. And what we're learning is that, for example, we know about the interactions between MDMA and ritonavir, and we have experience of patients feeling quite unwell and becoming very aggressive when they use MDMA on boosted PIs. And the social workers from Frankfurt brought their experience where apparently people on boosted PIs stop their antiretrovirals during the weekend when they take MDMA. So there are issues with drug-drug interactions. I think we just don't know enough about it. And this is a very interesting article that describes the chemsex use in London, and it was published in September 2014 in the Lancet HIV. So in conclusion, all antiretrovirals may be associated to toxicity. Sometimes we might learn about it only when cohort studies are run, only when clinical practice data are produced. And I think we just need to listen and learn, again, to real clinical data, but also obviously to people that we see in our clinics. And drug-drug interactions are not going away, and they may affect people's well-being. And they're not going away because the people we see in clinics see different prescribers, because we see our patient less and less. We see them twice a year now, so during those 6 months we don't see them, anything can happen. Our patients are aging, the use of recreational drugs is going up, our patients are on polypharmacies, rates of hepatitis C co-infection are going up, and so on. Thank you very much.